The bills on today's agenda are intended to improve the health care provided to our nation's veterans. Although I have a few questions on a few of the bills being considered, I look forward to addressing our policy concerns and working with the minority on these bills moving forward. In accordance with committee rules, the subcommittee has contacted the Congressional Budget Office seeking informal preliminary cost estimates for each of these bills being considered this morning. While many of the bills on our agenda will most likely have a score, we do not have estimates for all the bills on today's markup. None of the bills today include the offsets that would be necessary to move the bills forward. However, as we discuss what bills will go to the full committee markup and then to the floor, we will add offsets to ensure that we are in accordance with House rules and that we are protecting the American taxpayer. I look forward to working with Ranking Member Brownlee and Mr. Landsman in this case, and other members of the subcommittee to find offsets for the common sense proposals considered today. Of note, there are still multiple opportunities to improve and make necessary changes to these bills. Ranking Member Brownlee and I will continue working with our colleagues on the committee and any stakeholders that have feedback on these bills as we continue to work through the legislative process to bring the best bills forward. A majority of the bills on today's agenda, including my bills focused on ensuring quality mental health and prosthetic care, have bipartisan support. I understand, however, that the minority may have concerns with several of our bills, including Representative Franklin's bill, H.R. 9146, which would require VA to consider continuity of care in deciding whether veterans can receive their care in the community. I commend Representative Franklin for his efforts. Veterans, especially those seeking mental health care providers, should have the opportunity to remain with clinicians they are comfortable with and who are getting results. I now recognize Representative Landsman as the ranking member for any opening remarks he may have.
Well, thank you, Chairwoman, for organizing this afternoon's markup. In the interest of a prompt proceeding, I'll go ahead and forego any opening statement, and I yield back.
Thank you, Representative Landsman. I now ask unanimous consent to consider the following bills en bloc: H.R. 9496, H.R. 9324, H.R. 9478, H.R. 9525, H.R. 7504, and H.R. 9301. Hearing no objections, so ordered. The clerk shall report the bills.
H.R. 9496.
The bills were circulated in advance pursuant to committee rules. I ask that the reading of the bills be dispensed with and that the bills be open to amendment at any point. Without objection, so ordered. Does any member wish to speak on any of the bills included in the en bloc? Seeing none, are there any amendments to these bills that were not previously filed? Does any member wish to offer an amendment? Seeing none and hearing none, I now ask Ranking Member Landsman for a motion.
Thank you, Madam Chairwoman. I move that H.R. 9496, H.R. 9324, H.R. 9478, H.R. 9525, H.R. 7504, and H.R. 9301 be reported favorably to the full committee.
There is a motion to favorably forward the bills included on the en bloc. All those in favor say aye. All those opposed say no. In the opinion of the chair, the ayes have it, and the bills are favorably forwarded to the full committee. The motion to reconsider is laid upon the table. I now call up H.R. 9485. The clerk shall report the bill.
H.R. 9485, to amend Title 38, United States...
The text was circulated in advance pursuant to committee rules. Without objection, the first reading is dispensed with, and the bill is now open for amendment at any point. I now recognize myself for several minutes to speak in support of H.R. 9485. I applaud Representative Self's efforts to make sure every veteran has access to the religious care they require or desire. My staff has heard of several instances where veterans are not adequately provided this support. Regardless of a veteran's faith or lack thereof, the VA must facilitate both physical and spiritual healing. I yield back the balance of my time. I now recognize Ranking Member Landsman for 3 minutes to discuss H.R. 9485.
Thank you, Chairwoman. I appreciate the intent of the bill and respect our veterans' face, and that they are often an important part of their identity. I know it's an important part of mine, and their approach to healthcare also important. However, the concerns that we have on this as it relates to this bill is in how it's written, that it may pose a risk to veterans and their personally identifiable information, including their private health information. The bill doesn't define what types of religious or faith-based organizations it is referring to, nor does it specify any limitations on how these organizations can use that information shared by VA chaplains. It also does not include any provisions for protecting this sensitive information. While there is nothing to keep VA chaplains from sharing information with veterans about faith-based organizations that may support their healthcare needs, sharing sensitive information about the veterans is not in keeping with how VA treats veterans' privacy. So that's the concern here is around privacy. This is the wrong approach potentially to connecting veterans to really important and oftentimes critically necessary faith-based organizations. And so I oppose the bill. Thank you, and I yield back.
Thank you. Do any members wish to be recognized on H.R. 9485? No amendments were filed. Does any member wish to offer an amendment? Hearing none, I now recognize Representative Luttrell, for a motion.
Madam Chair, when I move that the Health Subcommittee report H.R. 9485 favorably to the full House Committee on Veterans Affairs.
There is a motion to favorably forward H.R. 9485. All those in favor say aye. Aye. All those opposed say no. In the opinion of the chair, the ayes have it, and H.R. 9485 is favorably forwarded to the full committee. The motion to reconsider is laid upon the table. I now call up H.R. 9438. The clerk shall report the bill.
H.R. 9438.
The text was circulated in advance pursuant to committee rules. Without objection, the first reading is dispensed with, and the bill is now open for amendment at any point. I recognize myself to offer an amendment in the nature of a substitute. The clerk shall report the amendment in the nature of a substitute.
Amendment in the nature of a substitute to H.R.
I ask unanimous consent that further reading of the amendment in the nature of the substitute be dispensed with. I ask that it be considered base text for the purposes of the markup. Without objection, so ordered. I now recognize myself for 3 minutes to explain my amendment. The Fox Grant Program offers veterans an opportunity to connect with fellow veterans and ultimately the Department of Veterans Affairs in order to receive life-saving mental health care. My amendment to H.R. 9438 would ensure the program continues to succeed and improve. Importantly, the amendment would ensure that the successful Fox grantees could serve even more veterans by increasing grant amounts based on the number of veterans served. I yield back the remainder of my time. Does any other member wish to comment on the amendment in the nature of a substitute to H.R. 9438?
Madam Chairman, I wish to speak.
The chair now recognizes Representative Landsman for 3 minutes.
Thank you, Chairwoman. I am a big fan of the Fox Suicide Prevention Grant Program and believe this bill and amendment in the nature of a substitute as drafted may undermine our ability to oversee the grant program. The real issue is around, as drafted, my understanding is that it would reduce the amount of information grantees would be collecting and reporting, and that gets at our ability to not just oversee this particular grant program, but one of the things we're working on is trying to ensure that we have the data and VAs and their partners have the data to do continuous improvement and share best practices. So that is my objection.
Thank you, Representative Landman. Are there any amendments to the amendment in the nature of a substitute to H.R. 9438? Hearing none, the question now occurs on agreeing to the amendment in the nature of a substitute to H.R. 9438. All those in favor say aye. Aye. All those opposed say no. In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed with. Without objection, the motion to reconsider is laid upon the table. I now recognize Representative Luttrell for a motion.
Madam Chair, when I move that the Health Subcommittee report H.R. 9438 favorably to the full House Committee on Veterans Affairs.
There is a motion to favorably forward H.R. 9438 as amendment. All those in favor say aye. Aye. All opposed say no. In the opinion of the chair, the ayes have it, and H.R. 9438 is favorably forwarded to the full committee. The motion to reconsider is laid upon the table. I now call up H.R. 9146. The clerk shall report the bill.
H.R. 9146.
The text was circulated in advance pursuant to committee rules. Without objection, the first reading is dispensed with, and the bill is now open for amendment at any point. I now recognize myself for 3 minutes to speak in support of H.R. 9146. I applaud Representative Franklin's efforts to ensure continuity of care is factored into veterans' community care eligibility decision. VA should facilitate the best care for veterans, regardless of whether it is in the House or in the community. That's why I support H.R. 9146. I yield back the balance of my time. I now recognize Ranking Member Landsman for 3 minutes to discuss H.R. 9146.
Thank you, Chairwoman. The Mission Act was designed to ensure veterans can receive care from community providers when it is not readily accessible at the VA. There are 6 criteria under which a veteran may be eligible for referral to community providers, one of which is that the veteran and his or her VA clinician agree that community care would be in the veteran's best medical interest. This does not mean that once referred to a community provider, a veteran should receive care from that provider forever. Unfortunately, I think that is the intent behind this legislation, that veterans be able to continue care with community providers to which they are referred in perpetuity without any consideration of changes or improvements in the veteran's condition, or whether they can access more timely or high-quality VA care. So for that reason, I will oppose the bill.
Thank you. Do any other members wish to be recognized on H.R. 9146?
Done it after that.
No amendments were filed. Does any member wish to offer an amendment? Hearing none, I now recognize Representative Luttrell for a motion.
Madam Chair, when I move that the Health Subcommittee report H.R. 9146 favorably to the full House Committee on Veterans Affairs.
There is a motion to favorably forward H.R. 9146. All those in favor say aye. Aye. All opposed say no. In the opinion of the chair, the ayes have it, and H.R. 9146 is favorably forwarded to the full committee. The motion to reconsider is laid upon the table. I now call up H.R. 8562. The clerk shall report the bill.
H.R. 8562.
The text was circulated in advance pursuant to committee rules. Without objection, the first reading is dispensed with, and the bill is now open for amendment at any point. I now recognize Ranking Member Landsman for 3 minutes to discuss H.R. 8562.
Sorry. Thank you, Chairwoman. Glad to see this bill considered today. This bill is a matter of fairness and access for Native Hawaiian veterans, it will provide parity so that Native Hawaiians are not subject to copays at the VA like other Native population. I look forward to supporting this legislation to provide parity to our Native Hawaiian veterans, and I yield back.
Thank you, Representative Landman. Do any other members wish to be recognized on H.R. 8562? Seeing none, no amendments were filed. Does any member wish to offer an amendment? Hearing none, I now recognize Ranking Member Landsman for a motion.
Madam Chairwoman, I move that H.R. 8562 be reported favorably to the full committee.
There is a motion to favorably forward H.R. 8562. All those in favor say aye. Aye. All those opposed say no. In the opinion of the chair, the ayes have it, and H.R. 8562 is favorably forwarded to the full committee. The motion to reconsider is laid upon the table. I ask unanimous consent that the committee staff be authorized to make technical, clerical, and conforming changes to the bills favorably forwarded today. Hearing no objections, so ordered. I thank the members for their attendance, and the subcommittee is adjourned. Thank you. Sure. Chicken's going to take the exactly. Appreciate you. Thanks very much.
We will now get right into our oversight hearing today on the Veterans Crisis Line. Before we dive into the substance of today's hearing, I would be remiss if I didn't acknowledge that we are in the middle of Suicide Prevention Awareness Month. We are losing on average 17 veterans a day to suicide. Too many veterans and active duty service members live with the invisible wounds of their service. We must continue to work to break the stigma surrounding mental health and get veterans and service members the support they may need. There should be no wrong door when it comes to mental health, and PTSD is treatable. The VA has an incredibly large mental health and suicide prevention budget and a wide range of programs to provide services and treatment to veterans. We must ensure these programs are reaching veterans where they live. One of these community-based partnership programs would be reauthorized through H.R. 9438, the No Wrong Door for Veterans Act, a bill Chairwoman Miller Meeks recently introduced. There is no one-size-fits-all approach to mental health care, and as House Republicans in the subcommittee have made clear, this Congress is on the VA to ensure every veteran has access to the mental health care they have earned. This brings us to today's oversight hearing of one of the VA's suicide prevention tools, the Veteran Crisis Line. The Department of Veteran Affairs established the Veterans Crisis Line in 2007 as a 24/7 resource to provide confidential help to veterans and their loved ones in need of support. In 2022, the National Suicide and Crisis Lifeline transitioned from the standard 10-digit phone number to the more recognizable 3-digit number 988. To reach the Veterans Crisis Line, callers can now dial 988 and press 1. The line is accessible through call, text, or chat. The intent of this shift was to make the phone number for the Lifeline easier to remember and more accessible for people who need immediate crisis support. For the VA, this meant an increase in callers and the need for a more robust operation. In the 4 years since the launch of 988, the Veterans Crisis Line has answered over 1.8 million calls. While the VA maintains a high call volume and a short average speed to answer time, I find the number of notifications to Congress involving outages and intermittent access issues concerning. In the past year, we have been notified at least 6 different times about issues with the Veterans Crisis Line, which have impacted almost 700 callers. I have heard from veterans in my own district about communication issues between the caller and crisis line staff. I'm interested to hear from the VA today about their adjustments and operations since 988 was implemented, as well as how they are ensuring that veterans always have access to the Veteran Crisis Line. We will also hear from the VA OIG regarding the review of the preparation and response of the Veterans Crisis Line team on the implementation of 988 Press 1. One veteran lost to suicide is one too many. I appreciate the work the VA has done, but the VA needs to be held accountable for ensuring that their Veteran Crisis Line is always accessible for all callers, especially given the year-after-year increases in the VA's mental health budget. To all the veterans and their loved ones listening today, if you need confidential support, please reach out. Your life matters, and we need you here. I now recognize Ranking Member Landsman for his opening remarks.
Well, thank you, Chairwoman. Excuse me one second. And thank you to our VA witnesses for being here today. As you've noted, this is a timely topic, as this month is Suicide Prevention Month. We are just coming out of Suicide Prevention Week. I'd like to take this opportunity to acknowledge the important conversations like the one that we're going to have today as we work to reduce the stigma and barriers for seeking help and let veterans know that support is out there if and when you need it. And as the chairwoman said, you matter a great deal. Any veteran lost to suicide is one loss too many. We are all committed to working with our partners in this room today and beyond to raise awareness and prevent veteran deaths by suicide. 988 is a crucial lifeline in our toolkit against suicide. Every call to 988 and to the Veterans Crisis Line is an opportunity to save a life. And every interaction has the highest stakes for the life and safety of veterans and their families. Because of this, it is critical that the Veterans Crisis Line responders, supervisors, and support staff are prepared to answer every call and text and provide the best support and response to contacts. That's why it's so important to take every interaction as a learning opportunity and identify what could be done better, which we will do here today. The Veteran Crisis Line was able to work collaboratively with the VA's Office of Suicide Prevention and the Office of Information Technology to execute a smooth transition to the new and easy-to-remember 988 press 1 number. This includes responding nimbly when outside vendors notified a VA that they wouldn't be able to provide services anymore, to find a way to provide those in-house. The crisis line also hired aggressively in anticipation of an increased call volume with the new member and were more than prepared with additional staff. As VCL works to define its staffing, including through ensuring it gets back to an appropriate supervisor to responder ratio, we stand ready to support and give the VA the resources it needs. This includes ensuring that the VCL staff are aware of the resources available to them. It is a very difficult job, and the importance of their work cannot be overstated. When the worst happens, VCL must make sure its responders know about and feel empowered to make use of the prevention services available to them. Since the transition from the previous 1-800 number to 988, VA has been very transparent with the committee about the minimal outages that have occurred. VA has worked diligently to mitigate any misconnections, track down veterans who were disconnected, and make sure their needs were met. We'll continue to monitor Veterans Crisis Line operations and the VA's applications of lessons learned to ensure we are preventing tragedies as much as humanly possible. The VSL remains a crucial component of suicide prevention efforts at the VA, the President, and this committee. I look forward to hearing from the VA about the important work of the VCL and the OIG on its oversight work and ways VCL can improve. Thank you, and I yield back.
I would now like to introduce the witnesses testifying before us today. We have Dr. Matthew Miller, the Executive Director of the VA's Office of Suicide Prevention. Dr. Miller is accompanied by Dr. Christopher Watson, the Executive Director of the Veterans Crisis Line, Dr. Brad Mills, the Deputy Director for Unified Communications in the Office of Information Technology. We also have Dr. Julie Kroviak, Principal Deputy Assistant Inspector General for Healthcare Inspections for VA's Office of Inspector General. Dr. Miller, you are now recognized for 5 minutes to deliver your opening statement.
Good afternoon, Chairwoman Keegans, Ranking Member Landsman, and distinguished members of the committee. Thank you for your thoughtful opening remarks and accurate. Thank you for the opportunity to discuss the Veterans Crisis Line on the 77th birthday of the United States Air Force. Accompanying me today, as you mentioned, is Dr. Christopher Watson, Executive Director of the VCL, and Mr. Brad Mills with our partners in the Office of Information and Technology. September, as you both mentioned, is Suicide Prevention Month. Everyone has a role to play in preventing suicide, and there is continued hope. I want to thank this committee for its support and continued collaboration. This critical relationship is reflected in the resources that Congress has consistently secured for the VA. In 2007, the VCL started with 14 trained crisis responders working out of a call center in Canandaigua, New York. Now, more than 1,000 crisis responders are available to any veteran, service member, or their loved ones 24 hours a day, 7 days a week, 365 days a year through call, text, or chat. The VCL crisis responders continue connections after the call, chat, or text by offering veterans a referral to over 470 local suicide prevention coordinators available in each VA medical center across the country. We know that over 80% of veterans who accept a referral to VHA care after calling the VCL for suicidal thoughts report the VCL played a significant role in stopping them from acting on those thoughts. The VCL continues to advance its services and operations through the National Suicide Hotline Designation Act of 2020. VCL simplified access to crisis services. To launch 988 in July 22, VCL partnered with SAMHSA and HHS, as well as the 988 Suicide and Crisis Lifeline, along with numerous phone carriers. Upon the 2-year anniversary of 988 launch, the VCL has successfully adapted to a 22% increase in calls per day, a 77% increase in texts per day, and a 27.5% increase in chats per day. This means that more veterans are getting the support they need from caring, qualified responders during times of crisis. Beyond meeting demand, however, quality matters. VCL is fully accredited by 3 organizations specializing in crisis call center operations: the American Association of Suicidology, the Commission on Accreditation of Rehabilitation Facilities, and the International Customer Management Institute. In its most recent accreditation visit, CARF awarded VCL a full 3-year reaccreditation for achieving 0 findings across all domains, including governance and quality. We were called a model crisis call center. Amidst 988 Press 1 implementation, we've experienced limited service interruptions impacting veterans. Although less than the previous year, VCL has experienced 12 notable outages or service interruptions, 80% resulting from external issues. These outages varied in scope and impact, however, none of them incapacitated VCL services. Our commitment to modernization and improvement is critical to ensuring VCL can promptly respond when interruptions do arise. Overall, 988 has been successful. We know that we're saving veterans' lives. 2 published studies recently have found veteran callers were over 5 times more likely to have less distress and less suicide ideation at the end of the call compared to the beginning. We're 11 times more likely to have reduced suicidal urgency at the end of the call than the beginning. Before I close, I want to acknowledge the 2023 OIG report of a patient's death by suicide following contact with the VCL in 2021. From the painful lenses of retrospective review, I'd like to share that we've closed 8 of the recommendations, 2 are concluding, and 1 has been submitted to OIG for closure. It's our earnest desire and responsibility to apply wisdom gained to strengthen processes for veterans. Madam Chair, this concludes my remarks. My colleagues and I are prepared to address any questions.
Thank you, Dr. Miller. Dr. Kroviak, you are now recognized for 5 minutes to deliver your opening statement.
Thank you, Chairwoman Kiggins and Ranking Member Landsman and subcommittee members. September is Suicide Prevention Awareness Month, and I am grateful for opportunities such as this hearing that bring greater attention to an issue that continues to devastate individuals, families, and communities: veteran suicide. In that VA's #1 clinical priority is reducing the rate of veteran suicide, the OIG provides oversight of the many clinical and other support services aimed at treating veterans at risk for suicide, as well as reviewing the care provided to those veterans in acute crisis. For example, our proactive reviews of vet centers have evaluated the compliance of vet center staff coordinating mental health care with VHA clinical staff when a client is deemed high risk for suicide. We've also developed a new cyclical review that assesses the environments and quality of care provided to those veterans in need of acute mental health inpatient treatment. We look forward to briefing your staff next week before this very first report publishes. And through several hotline reports, we reviewed the quality of services provided by VCL responders to veterans in crisis. There is almost no service that VA provides that carries the same high level of risk and urgency than the services provided by VCL responders to a veteran in an immediate mental health crisis. Veterans, their families, and caregivers rely on this crisis intervention service, and its role in reducing veteran suicide cannot be overstated. My written testimony details several failures of VCL staff in providing high-quality interventions to veterans in crisis, failures that contributed to very tragic outcomes. Deficiencies included incomplete risk assessments, missed opportunities to initiate rescues, and misleading documentation of the interactions with veterans. These deficiencies do not define VCL services, but they do point out serious gaps in VCL's quality assurance processes. These gaps are barriers to quality crisis interventions in that they undermine leaders' abilities to ensure accountability and continuous process improvement. Our most recent report reviewed VA's 2022 implementation of the National Suicide Prevention Hotline 3-digit dialing code. Overall, our team found that VCL leaders provided their staff with the necessary equipment and technical support, and they significantly increased responder staffing to meet an anticipated increase in calls. We were also encouraged by VCL leaders' quality data collection and analysis practices. We did find opportunity for VCL leaders and supervisors to be more supportive of frontline staff by assuring awareness and access to post-vention resources. As with any crisis intervention service, the demands and expectations of responders are significant, and they must have access to resources that support their well-being and resilience. The most recent veteran suicide statistics are dismal and must serve as a reminder that more must be done to engage veterans in the care they need and ensure that that care is delivered consistently and to the highest standards. We recognize and appreciate the tireless efforts of dedicated VHA staff, including VCL responders, who do just that every day. The OIG remains committed to conducting impactful oversight work aimed at further strengthening all VHA's suicide prevention programs and services. This concludes my statement. I'd be happy to answer any questions you or members of the subcommittee may have.
Thank you, Dr. Kroviak. We will now proceed to questioning. I will now recognize myself for 5 minutes for questions. Dr. Miller, what is the process for identifying the location of a veteran if they are not willing to provide that information or are calling from a location that is not the same as their phone's area code?
Thank you for the question. I think first things first, an important aspect of Veterans Crisis Line Services is allowing veterans to interact with us anonymously if they so choose. Therefore, we want to be very careful how much we pursue information from the veteran unless it's absolutely necessary to provide them with the highest quality care. There are situations where perhaps in an emergency dispatch, we may need the veteran's location. About 5 to 6% of our overall call volume includes the need for emergency dispatch. In such a case, we ask the veteran for their identifying information. We ask for their location. If the veteran is not able to provide that information or chooses not to provide that information, we have options that we can engage to try to locate that veteran based upon a number of variables. Again, that's last resort and only in emergency situations.
Thank you. And Dr. Miller, the OIG's recent report highlighted concerns that not all veteran crisis line staff were aware of post-vention services. The responders may deal with incredibly emotional and triggering calls. So how is the VA ensuring that responders have the support and resources available to them?
Great question. We appreciate your attention to the well-being of our crisis responders. This is an area that we have been working assiduously on. Dr. Watson, I defer to you for specifics.
Yes, thank you for that question. I believe the online survey was done approximately in May of 2023. So since that time, up to the current state, we have provided post-vention resources. We have had all of our staff take training on that, and the only ones that have not been involved are anyone who's on extended leave. We have an employee assistance program, so we have sessions involved there. We provide yoga, meditation, stretching, other types of things to help our callers unwind so that they will be most proficient in providing the best services for our callers.
And what is the attrition rate for the Veterans Crisis Line responders?
You're referring to the turnover rate,
Yes.
perhaps?
Yes, sir.
Okay. The turnover rate by industry standards is rather low. It averages around 15% overall. We also note that in our turnover, you may have turnover from a responder to a supervisor or to a workflow coordinator, which we consider advancement and growth and a positive indicator.
Along those same lines, just asking about staffing, are you fully fielded? Do you have enough employees? Are you at 100% for your workforce?
We feel that from a staffing perspective, we're in a very good place right now vis-a-vis our demand. Some key indicators of that, we mentioned the 2023 OIG report from a 2021 situation. The heart of that situation was a responder working overtime. And with our hiring, what we've been able to do is we've been able to decrease overtime by greater than 25%. We've been able to decrease the time that responders are in concurrent chats and text messaging as well, so that they can focus on the veteran in front of them, whether it be chat, text, or phone.
Good, thank you. Thank you very much. And Dr. Kroviak, why are silent monitors important for the oversight and quality review of Veterans Crisis Line responders?
We very much feel that it's such an important quality assurance process to have real-time understanding of the quality of interventions that are provided, and then from there, supervisors can make decisions about whether their staff need more support, more training, retraining, or long-term, tracking and trending how performance would influence allocating resources differently in training and retraining programs.
Thank you. And also, Dr. Kroviak, in your testimony, you state there are concerns about leadership accountability and the handling of errors or performance deficiencies by VCL staff. What recommendations has the IG made to improve VCL leadership practices to ensure greater accountability and adherence to high reliability organization principles?
Yeah, we have multiple recommendations throughout the reports I cited in my written testimony, aimed at just that, strengthening the quality assurance program to ensure that leaders have an understanding of the performance and can act accordingly in that area of accountability.
And do you believe VCL leadership is taking the appropriate steps to implement these recommendations?
We do. They've been very responsive to the recommendations that we've made.
Great. Thank you. And I will yield, and I will now recognize Ranking Member Brownlee for any questions she may have.
Thank you, Madam Chair. Thank you to the panel. I apologize. I was late. I was in another committee hearing voting. Anyway, I wanted to ask Dr. Watson, can you speak to the extent to which VCL is offering culturally competent training for staffers, particularly as they are preparing to interact with the LGBTQ plus community, as well as women, actually?
Thank you so much for that question. That's very, very important to us. And we have training for our LGBTQ plus population as part of an annual training. We also have training for women veterans. We have training for veterans who are living with military sexual trauma. So there's a 3-hour training for new employees. So these are concerns that are very important to us. And we also have a resource SharePoint available for resources for our special populations.
Thank you. Have you been in your position overseeing this from before COVID to currently after COVID?
Thank you for the question. I have not. I was sworn in April of this year.
Okay, because one of my questions is really around, these are very sensitive, delicate, trying, sometimes heartbreaking jobs that people are doing, obviously very critically important. And I'm just wondering, when I read through the testimony and staff report, I was feeling very much like, how is this, how is this optimal where people are working remotely and not working together to sort of support each other? So I guess since COVID, everybody started to work remotely and stayed that way, and I presume the decision was made to stay that way because they felt as though that was optimal. And I'm just wondering, do you think it is optimal? You know, my gut reaction seems to be, I'm not so sure that is optimal.
Thank you for the question. We do feel like this is optimal for the organization to have responders across the country. They are connected through our virtual meetings. We have a tiered huddle system that helps them to remain connected, not only on providing the best metrics for the services that they provide to callers, but it also keeps them connected as sub-work groups. So we think this is something that is effective.
So those are meetings that aren't, they're meetings kind of across the country, not divided up by VISNs or anything like that? These virtual meetings that you're talking about?
Right, these are virtual daily huddle meetings where we look at the events of the previous day.
And this is for everyone working on a crisis line across the country?
Correct.
Okay, and so how do you know that they're getting the support that they need when you're talking to, I guess, thousands of people during these meetings?
Great question again. We really depend on regular feedback from our employees on whether the meetings are helpful, are we addressing and answering the right questions for them, and providing the support. So it's something that we consider continuous process improvement.
Dr. Kroviak, did you, is this an issue that you got some sense of in terms of talking to the staffers who are doing this?
So we, in our most recent report with the 988 conversion, we did find an issue with challenges actually related to hiring supervisors for on-site work. So it's almost the opposite of what you're suggesting, in that by offering remote positions, VA was more able to attract the talent that they needed in that supervisory role to correct the ratios that we found so concerning between supervisor and responder. So it was not a finding from that work.
So, most of the people that you're hiring are being trained or are coming in with experience, whether they're psychologists or whatever.
So we're not doing the hiring. I'd have to defer the hiring criteria to Dr. Miller.
Okay, but
we
in
did
terms
not
of your
specifically.
conversation, everybody was, that you're saying, and I read that in the staff report, that it was easier to hire quality people for a remote job than it was to come in-house.
From our work, that was at the supervisor level. They found it challenging to recruit supervisors for the in-place positions as opposed to the virtual positions. And
Okay, all right. Anyway, I think you've answered my question in terms of another question I had to making sure that, VA employees are getting the post-vention services that are available to them, and making sure that everyone is knowledgeable and aware. That I think from the OIG report, there was some issue around that wasn't getting out. So I think it's critically important that those services are there immediately, just as though it's critically important that we answer the phone immediately and serve those veterans who are in trauma immediately, but we need to help the people who are helping others and making sure that they have the supports that they need when they need them. Thank you. I yield back.
Thank you, Ranking Member Brownlee. The chair now recognizes Ms. Radewager for 5 minutes.
Thank you, Madam Chair, and I want to thank the ranking member for holding this hearing. I also want to welcome the panel. Thank you for being here today. Dr. Miller, we've heard that there's a working group to discuss the routing issues for crisis line calls. Has VA identified solutions to geographically locating veterans in crisis?
Thanks for the question. You are well aware then that this week SAMHSA announced the pilot implementation of geo-routing, geolocation services. And I think that this is really important for 988 overall. It's going to help 988 to link callers to more localized and the most localized crisis call centers, and in turn, resources to address their needs. Within the VA, the geolocation services for the purpose of providing localized care are less of a presenting issue with our callers and our daily operations. As a national call center, we link each caller to the most local facility and suicide prevention coordinator therein. Again, we're averaging about 15 to 17% of all phone calls result in a voluntary SPC referral from the veteran.
When the decision was made to hire more responders, Dr. Miller, why did VA fail to ensure that the appropriate number of supervisors were simultaneously hired?
I don't think it was a failure, to be honest with you, from my perspective. I think it was a developmental issue and occurred over a period of time where phase one necessarily involved hiring qualified responders. Phase two then required building up the supervisor cadre. I'll also note that the 1-to-10 ratio is a ratio that we developed and stated as a target. It's not based in anything that is policy. It's a goal. We're currently at a ratio of 1-to-8. We think that we're at the right place with that, largely because 98% of responders right now are monitored every month by their supervisor.
So from the congressional notifications, Dr. Miller, we've received about outages and intermittent access issues. Approximately 675 callers have been impacted. What's VA's procedure to connect with these dropped calls, texts, or chats?
Yeah, it's really important that we follow up. We are one of the few crisis call centers who engages follow-up for dropped or abandoned calls. We've developed, I think, a pretty thorough standard operating procedure for that. Dr. Watson, would you like to share more about the SOP?
Yes, and thank you for the question. We provide, at the minimum, 3 calls across 3 different shifts to callers that we need to reconnect with and do outreach to. The percentages of those that we have reached is 74%. The ones that we have not reached are due to numbers not being correct or inoperable, and or the caller has already reached back to us, so we've already made a connection. So this is something that we take very seriously in terms of making sure that the experience and any type of disruption is addressed promptly.
Thank you, Madam Chairwoman. I yield back the balance of my time.
Thank you, Ms. Radewagen. The chair now recognizes Ms. Budzinski for 5 minutes.
Thank you, Madam Chair, and thank you, Ranking Member. Thank you for bringing us together to talk about this important issue surrounding 988, the Veterans Crisis Hotline. As my colleagues have really already pointed out, the Veterans Crisis Line has been instrumental in reducing veteran suicides. This has been one of the most important tools to reach veterans in distress, and it is especially important that we're reaching our veterans living in more rural areas, which tend to be harder to contact. According to the study by the American Association of Suicidology, rural vets have had a 22% higher risk of dying by suicide than their urban counterparts. And these are disturbing disparities, but I believe that the Veterans Crisis Hotline can help us reduce these numbers for all veterans, including our rural vets. My question is really for Dr. Miller. How is the Veterans Crisis Line coordinating with local law enforcement to respond to calls, especially in rural areas where resources may already be thin?
Thank you for the question. You're 100% correct that rural or highly rural veterans represent a higher statistical risk for suicide. Rural veterans also disproportionately die secondary to firearm self-inflicted wounds. We work closely as needed with local law enforcement, particularly in rural areas. We offer resources and training for law enforcement. We're also engaged in law enforcement communities of practice to talk about safe and effective ways to intervene when engaging in an emergency dispatch with a veteran.
Mm-hmm. Could you see any improvements that you might identify that could be made just to strengthen the connection and response in rural areas?
I think there's always opportunities for improvement. I think one area that I have in mind most immediately is the more that we can respond using broader response teams and not just law enforcement. So response teams that also consist of trained social workers, peers, and peer support specialists. I think that that's going to improve the experience and outcomes for everyone involved.
Okay, thank you. In a similar vein, I'm wondering about the safe continuity of care and ensuring a seamless transition of also veterans' health records when they use the Veterans Crisis Line. Dr. Miller, again, how is the VA planning to improve coordination and sharing of information regarding the outcomes of calls into the Veterans Crisis Line and the VA facilities that may be providing care to that veteran, particularly to ensure the patient's electronic health record is updated in a timely manner?
Mm-hmm. We walk a really fine line there, to be completely honest with you. The fine line that we walk is veterans and service members call us because they believe we're safe. They call us because they believe it's confidential, and if they so choose, it's anonymous. Therefore, our documentation system is separate from the VA health record. However, it has interoperability and linkages through the suicide prevention coordinators. So something that we've been careful to do is ensure that we're continually updating policy, practices, standard operating procedures for communicating information in VCL system to information in VA care records through the suicide prevention coordinators.
Okay. Well, thank you. I just want to really close by saying a big thank you to the VA and the staff of the Veterans Crisis Line for providing this important tool and really what a difference it's making in communities and for our nation's veterans. I just want to say a sincere thank you.
Thank you.
So thank you, and I'll yield back the balance of my time.
Thank you. The chair now recognizes Mr. Van Orden for 5 minutes.
Thank you, Madam Chair. Dr. Watson, what percentage of these folks are working from, wait, let me start this way. Who's answering the phone?
Thank you for the question. The crisis responders.
Yeah, who is that?
These are staff that are across the country.
Okay, and they are who? They're veterans, they're psychologists, they're nurse practitioners, they're...
Anyone who has a social science background could be a crisis responder. So they could be any of the above.
So a social scientist from Cleveland that has never spoken to a veteran in person could answer the phone and try to talk someone off a ledge, is that right? The answer is yes. Okay, what percentage of these social scientists are working from home?
Anyone who's on the crisis responder is working from home.
So
working remotely.
100% of your staff, the social scientists that are answering the phone that may or may not ever actually seen a veteran in person, the 100% are working it from home. Is that right?
That's correct.
Okay. How much do they get paid?
I don't have that information. We can take that for the record, though.
Yeah, let's do that. How many of the vets that call 988 go on to commit suicide?
I'll be happy to take that if that's
It is, Dr.
acceptable to
Miller.
you, sir. The veterans who contact the Veterans Crisis Line have a higher rate of suicide and risk of suicide. The good news, and by higher rate.
Stop. So you're telling me a higher percentage of veterans that contact the Veteran Suicide Line and talk to a social scientist that's never seen a veteran in their life in person have a higher rate of suicide, is that correct?
Within 12 months of that call, yes, sir, that is correct. They have about 10.5 times higher risk. However, I'll also note that in the last 2 years of available data, we have significantly reduced the suicide
So,
rate.
sir, if it's 10.5 times higher rate of suicide for people to contact you as of 2 years ago, what was it 3 years ago?
3 years ago, it was 10.5 times, sir.
And what is it now?
There's been a 30% reduction in suicide.
Sir, I'm a
deaths.
retired enlisted guy. Can you do the math for me on that? Like, what percentage is that?
I'm percentage related
So it's
to
10
what,
and a half
sir?
times greater. Okay.
There have been 284 less veteran suicide deaths in the Veteran Crisis Line population.
Roger
from
that. Okay,
2019
I have limited
to
time. I got you. I want all this on paper. Did you think that Zoom school online learning during the COVID buffoonery was optimal? Do you think the educational outcomes for children that did Zoom school, think they're on par with their colleagues that went to in-person school?
That's not an area I've studied, sir.
The answer is hell no. Is it more important that a veteran doesn't commit suicide or that your staff gets to work from home?
It's most important that a veteran doesn't commit suicide.
Okay. So if we are paying you to find social scientist people that can have no contact with a human veteran ever, and they're sitting on their couch, how do you know they're working? How do you know that?
We have indications of their productivity. We have indications of
Sir,
the
their
calls
productivity
they're
is a 10.5 times higher veteran suicide rate than someone that doesn't talk to them.
I'd also say that their productivity is 284 saved lives.
That's
since
fantastic,
2020.
but that is a horrible, horrible way to justify this, doctor. If 10.5 times more veterans commit suicide that talk to you that don't, couldn't we reasonably say that more veterans would not commit suicide if you didn't exist?
What we can reasonably say is that
So that is, you're literally sitting next to Dr. Watson. So if we could do a little Sherlock Holmesy stuff here, deductive reasoning, the answer appears to be yes.
I disagree with that.
Well, you can disagree all you want, doctor.
Thank you.
You can. But what I'm telling you is this is not working. You actually may be contributing to the problem. With that, I yield back.
I think we have data that tells it is working and is effective. Thank you.
I just had a couple staffing questions out of curiosity. If in one day, how many calls might and assuming it's like an 8-hour shift, I don't know how you have your shift set up, but how many calls might one provider receive in a day or in a work shift?
I don't have that particular answer. Thank you for the question. For one crisis responder, we do receive about 2,500 calls per day on average. Some days more, some days less.
Okay, that's nationwide?
Correct.
Okay.
I also believe that the number of calls answered can vary by day. For example, Monday tends to be our highest volume call day. So the number of calls answered by one responder on a Monday would probably be different from the numbers that same responder on a Tuesday. It's higher in the fall than it is in the winter. So there's some seasonality to it as well. On average, you're looking at a responder with an average handle time of 43 to 45 minutes per call. So across shift, you're looking at around an average of probably 5 calls on a particularly busy day.
Okay, now how many responders do you have working in one day?
That depends on the day, that
Okay.
depends on the time of year, and
Yeah.
that depends on the shift.
Okay.
We use forecasting to predict call volume per every 15 minutes, and then we staff accordingly, and then we staff for a 15 to 20% surge just in case there's a surprise in the numbers so that we're available.
And I'm assuming things like holidays, you have sufficient staff for, and
We do. What we've actually learned, though, is it's not the holiday that's busy, it's the day after the holiday that tends to be more busy, particularly the Monday following a holiday. So we staff accordingly.
if that crisis line provider deems that the veteran who's calling needs immediate care, do they have any problem getting them to be seen at the closest facility, be that a veteran hospital or even civilian healthcare? But can they always make that connection for them?
Yeah, as we mentioned, we always use the connection with the suicide prevention coordinators. About 17% of calls result in that referral, and the suicide prevention coordinators follow up accordingly. That was actually one focus of a recent OIG review, making sure that we're syncing and coordinating with SPCs at the local level to ensure that they're following up timely on veteran referrals through the VCL, and that recommendation was closed.
Okay, good, thank you. And my last question, have you ever had I've been to different crisis centers, and one recently, it was a housing crisis line, and they had all the people in one room and in cubicles answering the phone. Has it ever been done in person, or has it always been done remotely, the people answering the phones?
It's, so since it originated in 2007 in Canandaigua, New York, that was actually at the Canandaigua VA in New York, we maximize the market within Canandaigua. We expanded to Atlanta. We maximized the market in Atlanta. We expanded to Topeka, Kansas. That is about the approximate time that COVID hit.
Has there been any discussion about going back to an in-person setting?
We're open to whatever works best for veterans and provides the highest amount of access and quality of services. So that is a window that I think should always be open and a consideration if it's best for the mission.
Thank you very much. And Ranking Member Brownlee, did you have any further questions?
Yeah, just to follow up on that, I have, I think, sort of similar concerns about is working remotely, have the support systems in place. And it just seems to me if people are working together, and particularly people who are onboarding and who are new can listen to an experienced person and how they speak. So I'm just, you know, there seems to be, in my mind, I mean, again, I have no data behind this and no science behind it at all, but my gut just sort of says, gee, it seems like it would be better if people were together as opposed to, you know, working alone in their homes. But, I mean, do you have, you said, well, we should be open to it. I mean, do you have an opinion of what is the better model that is going to best serve our veterans and making sure that the good staffers who are doing this work are taken care of as well?
I don't think that we would have been able to hire as quickly as we have in the last 2 years if we did not have remote as an option. I also know that it was very possible that at any moment the Veterans Crisis Line service could have been wiped out by a responder walking in COVID positive to a call center and then spreading that and us not having service capability. But I'll tell you as well, I went to Canandaigua a couple weeks ago and I just said, I'm here, come if you want to talk, and my schedule was full and talking to responders. And one thing they said, they miss the water cooler. They miss talking to each other. They miss that connection. And they were offering me a myriad of ideas of ways that we could improve upon the water cooler connection. I'll also note that we have less staff-to-staff complaints and concerns as well. So there's a balance there that we keep in mind, but I think your sensitivities are accurate and correct.
Thank you for that, and I was just wondering if you wanted to respond to some of the questions that Mr. Van Horn was asking, Van Orden was asking, and it seemed as though you had more to say and didn't have a chance to say it, and I just wanted to give you that chance.
I think that, yes, thank you. I do have more to say to that. Obviously, I believe that the Veterans Crisis Line is highly effective. I think it's very meaningful to say that the suicide rate for the Veterans Crisis Line caller population reduced by 30% from 2019 to 2020, and then an additional 20% from 2019 to 21. This converts to 500 lives, 500 individuals who are alive today if that decrease had not occurred. We are dealing with a significantly high-risk population. I think that it's meaningful to say that veterans report that they are 11 times less likely to engage in suicide behavior at the end of the call than at the start of the call. I also believe we have opportunities to learn and grow. We're all interested in significantly decreasing, eliminating veteran suicide, and we have opportunities for improvement.
Thank you for that. I think the point you were trying to make, or I thought made pretty clearly, is that when a veteran is calling the call center or crisis center, they're in major crisis, so they are heightened at risk. And of course, we want to save every single life, but sometimes it just doesn't work out that way, and we lose some veterans from it. But not that if it wasn't there, then we would have less suicide rate. That doesn't make any sense to me at all. And I thought that's the point that you were trying to make. But anyway, I appreciate your comments on that, and I'll yield back.
Thank you. And the chair now recognizes Mr. Van Orden for 5 minutes.
So I am much more blunt than my distinguished colleague, Ms. Brownlee. And you said that her sensitivities appear to be accurate. That if people could get together, they would perform at a higher level. I was super duper clear asking you these questions. What's the most important thing? What did you say then?
Said that they would report higher satisfaction with work if they were able to be more connected interpersonally.
So, okay, man. If you have a workforce that enjoys going to work, enjoys their environment, are engaged, and can be held personally accountable directly through observation, could we just make the bold leap saying that they would perform at a higher level?
We have a very satisfied workforce right now, according to all employees.
Okay, you are, at this point, you're obfuscating. You said that a veteran calls, they're 11 times less likely to have ideation or less likely want to commit suicide at the end of the call from the beginning, correct?
Correct.
Okay, so please help me put this together. If someone is 11 times less likely to commit suicide at the end of a phone call than they were from the beginning to phone call, but they're 10.5 times more likely to commit suicide after they call you. I mean, those are, we can play back your testimony. That's what you're saying. It doesn't make any sense. And this is why I'm more blunt. With Senior Chief Mike Day, I've had 21 of my friends, Navy SEALs, commit suicide. 21. And this sort of dancing around this stuff is not appropriate, man. These numbers, if you said someone is 11 times less likely to sound like they want to kill themselves at the end of a phone call, but they're 10.5 times more likely to kill themselves after they talk to you. That doesn't make any sense, sir. I'm the longest serving enlisted member of the military ever to be elected to Congress. So rocks are heavy, trees are made of wood, gravity's real. This doesn't make sense.
Within 12 months, sir.
Okay.
So there's a big...
Sir, does it matter if someone kills themselves within 12 months or 13 months or 15 months? They're still dead.
That is correct, but what it does matter is in terms of the effectiveness of the Veterans Crisis Line services. When the individual immediately gets off the phone with us, the individual is less likely to be dead. In 12 months that follows, the individual is still high risk for suicide, which
Sir,
is
I am
why-
in that patient category. So I know what the hell I'm talking about. I didn't read this in a book. So that's why you got these social scientists never talk to a veteran. They need to be talking to people like me. And they need to be talking to people like Matthew Brennan, my staffer. He's also in that group. We're doing something wrong, and we can do it better. And I am not in any way, shape, or form impugning your guys' intention at all. I get all my health care through the VA or through the VA system with community care. I know you're trying to do what's right. I'm just saying that, come let us reason together, because that's not what we're doing here. She's brought up some exceptionally great points, and we're just not addressing them. If we say that we think people are going to be more productive when they're at the office by sitting on their couch, because everybody here has done a Zoom call and they're doing 17 things at the same time. You know what I mean? They're not 100% focused on that phone call. I don't care who you are. You can't do it. You have distractions. And that's true, and you know that. So if the people need to focus their attention because Ms. Kiggins is sitting next to her, holding me accountable, knowing that I'm focused on my job, then that's what we need to do. We just need to do that. If your priority, and I believe it is, sir, is that we're always going to, she's Ms. Brownlee's correct. We can only get to functional zero for suicide, unfortunately. You are absolutely correct, ma'am. People are going to commit suicide, unfortunately. But if we're not doing everything we possibly can to get to functional zero, then we're not doing our jobs. That is what I'm saying. And these gobbledygooks of numbers just don't make sense. And if it can't make sense to me, like, I am the lowest common denominator, dude, and these things have to make sense to me, and they don't. And so I have 9 seconds, and with that, I want to compliment you. I do compliment you on your efforts, but I am not complimenting you on your outcomes. And with that, I yield back.
Thank you. And I just have one last question in closing. Is there any follow-up that's done with the people that do call and reach out? Does anyone check back in with them in a few weeks or months?
Absolutely. Over the last few years, we've developed a peer support outreach call center where we have hired 100% veterans who are certified in peer support, and they engage then in callbacks. We call it our Beyond the Call work, and we've found that that's been very successful and well received. We've also engaged Caring Contacts, which is monthly written outreach to veteran callers. We've heard feedback from them that is greatly appreciated and effective as well.
That's good. And just to close the lid on the in-person, and I know COVID through debate, and I know COVID had thrown everyone for a loop. We had a in-person roundtable meeting with mental health providers in my district on Saturday morning, and it was interesting to get a group of about 12 of them together, civilian providers from all different backgrounds, but to listen to them talk to each other and compare notes. And I was there, it was a listening session for me, but to listen to how much they learned from each other, just having them in that room for about a 2-hour period, I think there is a lot of benefit, as Ms. Brownlee mentioned. And I know hiring is challenging. There's not enough mental health care providers from the social work side to the a nurse practitioner, whatever side you're approaching it from. And so to have them, be centered at our VA medical side, I think it's doable, and I'm glad to hear you did it in the past. But I think all of us here would agree it's something we'd like to probably see explored a little more. But I'd like to thank everyone for their participation in today's hearing and for the productive conversation. I'd like to reiterate to all the veterans and their loved ones out there to please reach out if you need help. You can reach the Veteran Crisis Line by dialing 988+1 or connecting through a chat or text for confidential help. The complete written statements of today's witnesses will be entered into the hearing record, and I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objections, so ordered. I thank the members and the witnesses for their attendance and participation today. This hearing is now adjourned.